Hello guys, welcome back to Clinically Clear. Today we'll be starting with the refractive errors of the eye. So first, let's look at a normal eye. So a normal eye is said to be emmetropic. Now what does emmetropia mean? The normal refractory state of the eye in which parallel rays of light coming from infinity are focused onto the sensitive layer of a retina with accommodation being at rest. This accommodation being at rest is a very important point. So basically what happens? Parallel rays of light coming from infinity are parallel rays of light coming from infinity are focused onto the sensitive layer of retina with the accommodation being at rest. As you can see in this diagram, the parallel rays of light are coming, they're getting focused onto the retina. Now, normally in our eye, it is important to remember that at birth, obviously our eyeball is very short. So because our eyeball is very short, there is 2 to 3 diopters of hypermetropia. I'll come to what hypermetropia is. Basically, the light rays are being focused behind the retina. Obviously, at birth, the eyeball is very short, right? So the light rays are being focused behind the retina. So at birth, there is 2 to 3 diopters of hypermetropia. But functionally, the baby is still myopic. Why? Because the vision is still immature. Babies are able to see only what's very close to them, the newborn baby. So functionally they are myopic, but optically they are hypermetropic, 2 to 3 diopters of hypermetropia because of a very short eyeball. And also they have no lacrimal glands. The lacrimal glands in newborn babies is not well developed. So there are no tears. But eventually what happens? The eyeball grows and grows, the vision develops, and by 5 to 7 years old, child becomes emmetropic. And this remains so till 50 years of age. And beyond 50 years of age, there is now a tendency to develop hypermetropia. Why is there now a tendency to develop hypermetropia? Because of senile changes like cortical sclerosis of lens and decreased curvature of lens. Why is there decreased curvature of lens at old age? See, with old age, one thing you need to remember is ciliary muscles get weaker and weaker. So the tone of the ciliary muscle reduces, the accommodation reduces. So because of that, what happens? The ciliary zonules, the suspensory ligament of lens, they become tight, they become taut. So it pulls on the lens. So therefore, the lens becomes flatter. So the curvature of the lens reduces, the cortical sclerosis of lens. I'll tell how all this comes to hypermetropia once I start with hypermetropia. So now let's start with ametropia. Now emetropia is normal condition, ametropia. So basically, I forgot one thing. Yeah. So what happens with old age, 50 years of age, there is tendency to develop hypermetropia. So why is there tendency to develop hypermetropia? Because of senile changes like cortical sclerosis and decreased curvature of lens. I'll tell how it leads to hypermetropia later. So what happens with age? So there's increased hypermetropia and it comes back to 2 to 3 diopters of hypermetropia. So as you can see, newborn baby has 2 to 3 diopters of hypermetropia because of a very short eyeball. But it comes back to 2 to 3 diopters of hypermetropia because of tendency at old age. And only part of our eye which grows throughout life is lens. Lens grows throughout life. There is continuous deposition of lens proteins. So that is one more thing. Next, coming to ametropia. Now, what is ametropia? Ametropia is the abnormal condition. Very important. Emetropia is normal. So, abnormal refractive state of the eye in which parallel rays of light coming from infinity are focused either behind the retina or in front of the retina with accommodation being at rest. So, these are the only two changes in the definition. Everything else is the same as emetropia. So, this refractive error can be either uniocular refractive error or binocular refractive error. Binocular refractive error, both the eyes have to be open for the refractive error to be seen. So, anisoconia is what? One eye is interpreting the shape of the object differently and the other eye is interpreting it as differently. So because of that, when both the eyes are open, there is abnormal binocular interaction. So that is anisoconia. Anisometropia is what? Different refractive errors in both the eyes. Here you can have 1 diopter, here you can have 5 diopters. So when both the eyes are open, there is image blurring. That is binocular. We'll come to that in a different video. So first, let's look at uniocular refractive errors. Based on the type of correction, if you use spherical lens for correction, you have myopia and hyperopia. Hyperopia is also known as hypermetropia. If you're using cylindrical lens, there is something known as astigmatism. So uniocular, you have myopia, hyperopia and astigmatism. Binocular, you have anisoconia and anisometropia. Now let's come to the main topic of today's video. So that is hypermetropia. Now hypermetropia is also commonly known as farsightedness. Now it is the abnormal refractive state of light abnormal refractive state of eye in which parallel rays of light coming from infinity are focused behind the retina. So keyword is behind the retina. As you can see in this diagram, the parallel rays of light, they are being focused behind the retina. So because they are being focused behind the retina, it is said to be hypermetropia. It is a type of ametropia. Now let us classify this hypermetropia. First of all, we have etiological classification. The most common type of hypermetropia is axial hypermetropia. Now, what is axial hypermetropia? See, the normal axial length of the eyeball, that is antero-posterior diameter, that is about 24 mm. But what happens when the eyeball is short? So, when is the eyeball short? The axial length is less. So, that time what happens? Even though the refractory power of the eye is normal, the corneal curvature is normal, the lens curvature is normal, the power is normal, but the eyeball length itself is too short. So all the rays are being focused behind the retina. So for every 1 mm diameter, for every 1 mm shortening of the axial length, 3 diopters of hypermetropia you can see. For every 1 mm shortening of axial length, 3 diopters hypermetropia. This is the most common type of hypermetropia. Next type is curvatural hypermetropia. Basically what happens, any flattening of the cornea and the lens, basically corneal curvature and lens curvature reduce. Any flattening of the cornea and the lens, what happens? The radius of curvature increases, so the focal length increases, and when the focal length increases, the power reduces, the refractory power reduces, and therefore when the power reduces, it is not able to converge the light onto the retina. It is being focused behind the retina. The power of the eye is what converges it onto the retina, right? Our eye is a converging eye. The entire refractive system of our eye is converging in nature. So now because the power reduces, it is being converged behind the retina, and for every 1 mm increase in the radius of curvature, for every 1 mm increase in the radius of curvature, basically for every 1 mm reduction in the curvature because of increase in radius of curvature reduces, right? Whenever radius of curvature increases, what is supposed to be this curve becomes this curve. So basically there is 6 diopters of hypermetropia for every 1 mm increase in radius of curvature. Next type is positional hypermetropia. Basically what happens, think about it. Normally the lens is in, let's say it's in this position, and it is being focused onto the retina. But if the lens gets displaced posteriorly, there's not enough distance between the lens and the retina for it to converge it onto the retina. So posterior displacement of the lens can lead to positional hypermetropia. Index hypermetropia. Now what is index hypermetropia? Cortical sclerosis, especially in old age, cortical sclerosis decreases the refractory index, and when refractory index decreases, refractory power also automatically reduces, so it is now being focused behind the retina. So that is index hypermetropia. Two more you have known as aphakia. Aphakic hypermetropia, lens itself is absent. Now obviously without the lens, the light rays won't be focused onto the retina. The power is too less, right? So it is now being focused behind the retina, and this is a very high degree of hypermetropia. Apart from aphakia, you have something known as consecutive hypermetropia. Now, consecutive hypermetropia is a very human error. It is due to human error. Example, when I'm doing LASIK surgery for myopia, if I overcorrect the myopia, that is, if I decrease the refractory power too much. In myopia, you have too much refractory power. So during LASIK, I try to reduce the power, but I end up overcorrecting it. Then that will lead to hypermetropia. Similarly, during pseudophakia, that is during intraocular lens implantation, let's say I implant a lens, and if this lens has lesser power than what's required, so lesser power than what's required, underpowered lens implantation, that will lead to pseudophakic hypermetropia. So this is consecutive. So etiological, you have axial being most common, curvatural, index, positional, aphakic, and consecutive. Next, coming to the clinical classification. Now, under clinical classification, first of all, we have congenital hypermetropia. Congenital hypermetropia is present since birth. Since birth, how do you have hypermetropia? Basically, it is anisohypermetropia, where one eyeball is small. Congenitally, one eyeball is very, very small. So what happens? One side small eyeball, so that side will have hypermetropia. The other eyeball might be normal. So anisohypermetropia. Then you also have simple or developmental hypermetropia. Now, what is simple or developmental hypermetropia? This is actually the most common type. So what happens? You have developmental axial hypermetropia and you have developmental curvatural hypermetropia. Now, simple. In children who are growing, slowly their eyeball size also is increasing, right? So let's say during development, the axial length of the eyeball is a bit lesser than 24 mm. So what happens now? There is axial hypermetropia. This is developmental axial hypermetropia. Gradually it comes along. This is a very, very common type. Similarly, developmental curvatural hypermetropia in old age. As I said, in old age, the ciliary muscles get weaker and weaker. Now, because the ciliary muscles get weaker and weaker, the accommodation, the ciliary muscle contraction reduces, so the lens becomes flatter and flatter. So that is why it leads to curvatural hypermetropia. This is known as developmental curvatural hypermetropia seen in old age. So this simple or developmental hypermetropia is the most common type, axial in children and curvatural in old age. Then some pathological hypermetropia, which is very high grade hypermetropia, like microphthalmos, nanophthalmos, and congenital aphakia could be the causes for the same. Next, coming to secondary hypermetropia. Now, what is secondary hypermetropia? This is due to acquired changes during lifetime. Basically, acquired changes during lifetime, such as positional hypermetropia, where it is displaced posteriorly. Acquired aphakia, where aphakia is what? Absence of lens, right? So, because of any trauma, the lens gets extruded outside. So, traumatic extrusion of lens. Acquired curvatural hypermetropia, because of any trauma, there is flattening of the cornea, decreasing the curvature of the cornea. Then consecutive hypermetropia, as I told, human error. You overcorrect the myopia during LASIK, or you implant underpowered lens leading to hypermetropia. Now, functional hypermetropia is something unique. Basically, what happens? Here, the axial length is normal, the refractory power is normal, the curvature is normal, but because of third cranial nerve palsy, the medial rectus is paralyzed. And when the medial rectus is paralyzed, accommodation cannot take place. Now, accommodation is what? Convergence of eyeball along with ciliary muscle contraction. Now, when medial rectus is paralyzed, there is no convergence of eyeball. So, even though the power of lens is normal, even though the power is normal, the lens is normal, the eyeball is normal, because there is no accommodation. Now, accommodation is very, very important. Accommodation is what helps us see the nearby objects by increasing the power of the eye. Now, even though we are increasing the power of the eye, here accommodation reflex is not taking place, so that causes functional hypermetropia. Then you have senile index hypermetropia. How? Because of cortical sclerosis. Cortical sclerosis leads to senile index hypermetropia. Whereas senile curvatural hypermetropia, as I said, because of loss of ciliary tone with old age, the ciliary muscle tone reduces more and more. So because of that, what happens? The suspensory ligament of lens, the ciliary zonules, they become tighter and tighter and they pull on the lens. That causes flattening of the lens. So secondary hypermetropia, you have positional displacement, acquired aphakia because of trauma, acquired curvatural hypermetropia because of traumatic flattening of the cornea, consecutive hypermetropia, functional hypermetropia due to third cranial nerve palsy leading to loss of accommodation. Why? Because of medial rectus paralysis. Senile hypermetropia, which can be due to index, which can lead to decrease in refractory index like cortical sclerosis, or because of curvatural hypermetropia due to loss of ciliary muscle tone leading to flattening of the lens. So this is about clinical classification. So congenital, pathological, simple or developmental, which is the most common type, under which you have developmental axial in children and developmental curvatural in old age. And then you have secondary or acquired, under which you have 6 different subtypes. Then coming to role of accommodation hypermetropia. Now this is something simple but helps us understand the topic better. So basically what happens? Accommodation overcomes hypermetropia. That is the relation. So how does it happen? Think about it. What happens? Ciliary muscles contract. When the ciliary muscles contract, the suspensory ligaments of lens, the ciliary zonules, they become loose. So what happens? The lens which was flat, it bulges during accommodation. In accommodation, there is bulging of lens. So when there is bulging of lens, the curvature increases, and when the curvature increases, the power increases. So now what happens? Our body compensates, our eye compensates by accommodating, increasing the power of lens, so that the light rays which were being focused behind the retina is now being focused onto the retina. So basically, what does accommodation do? By increasing the power of lens through accommodative effort, it is able to overcome hypermetropia by increasing the refractory power and making it focus onto the lens, making it focus onto the retina. So this is the role of accommodation in hypermetropia. Next, coming to the components of hypermetropia. Now, what are the components of hypermetropia? So basically, total hypermetropia is equal to latent hypermetropia plus manifest hypermetropia. Now, what does this mean? So basically, let's break down each component. Latent hypermetropia is the refractory error that is corrected by inherent tone of ciliary muscle. That is, even without any accommodative effort. Even without any accommodative effort, our ciliary muscle will have some tone, right? That some tone would have caused some degree of bulging of lens, some degree of increase in refractive power. That itself would have corrected some of the hypermetropia. So the degree of refractive error that is corrected by the inherent tone of the ciliary muscle without any accommodative effort. The patient is not doing, there's no accommodation reflex taking place. It's just that the tone of the ciliary muscle itself is correcting some amount of the hypermetropia. Now, how can you reveal this latent hypermetropia? A patient comes to you in the OPD, you cannot see the latent hypermetropia. Why? Because his inherent tone of the ciliary muscle itself is overcoming it. So that's why you give cycloplegic drugs. So cycloplegic drugs, it abolishes, it completely paralyzes the ciliary muscle, so there is no ciliary tone, hence you can get to know the latent hypermetropia. And latent hypermetropia is a part of total hypermetropia, right? So that is why we say total hypermetropia is revealed only when the patient is cycloplegic. So to find out the total hypermetropia, we have to administer cycloplegic drugs. In children, the ciliary muscle tone is very, very high. So the latent hypermetropia can be 2 diopters, 3 diopters. But in adults, what we take as a standard value is about 1 diopter of latent hypermetropia. And with old age, as I said, the ciliary muscles get weaker and weaker, so the tone reduces, so it becomes 0.5 diopters and it decreases further and further and further. So, but classically we say that the latent hypermetropia is about 1 diopter. So this is about latent hypermetropia. Second component is manifest hypermetropia. Now, what is manifest hypermetropia? See, this is what, under manifest hypermetropia, we have two further components, facultative and absolute. Now, think about it. Now, through inherent tone of the ciliary muscle itself, we corrected some of the hypermetropia. Now, patient puts accommodative effort, that is further ciliary muscle contraction. So maximum accommodative effort, even that will also correct some amount of hypermetropia, right? So the part of manifest hypermetropia, the degree of manifest hypermetropia that is corrected by maximum accommodative effort, that is facultative hypermetropia. So what do you think absolute is? The remaining part of manifest hypermetropia, the part of manifest hypermetropia that cannot be corrected, that cannot be overcome even with maximum accommodative effort. Understood? So basically now the patient is putting maximum accommodative effort to overcome that hypermetropia. So the part of that manifest hypermetropia that is corrected by the maximum accommodative effort is facultative hypermetropia. The part of that manifest hypermetropia that cannot be overcome even with maximum accommodative effort is absolute hypermetropia. So think about it, with age what happens? There is weakening and weakening of the ciliary muscle. So because of weakening of the ciliary muscle, the maximum accommodative effort also gets lesser and lesser. So the amount of hypermetropia that you can overcome by the maximum accommodative effort also gets lesser and lesser. So facultative will go on reducing and absolute will go on increasing. So facultative shifts more into absolute hypermetropia. And by age 60, manifest hypermetropia becomes almost equal to absolute hypermetropia because there is barely any accommodative effort taking place, right? So manifest hypermetropia becomes equal to absolute hypermetropia. So I hope you understood, total hypermetropia is equal to latent plus manifest hypermetropia. To reveal the total hypermetropia, you must give cycloplegic drugs. Now let's come to the symptoms. So think about it. Let's say the patient has very, very mild hypermetropia and with a very low degree of accommodative effort, with very mild accommodative effort, the patient is overcoming that hypermetropia. So do you think they'll have any vision problems? No. So they are said to be asymptomatic. Now, there can be the hypermetropia can be a little higher, meaning the refractive error can be worse, but still the vision can be normal. How? Because of excessive accommodative effort. Patient ciliary muscle is contracting throughout the day, is doing accommodation throughout the day to overcome that hypermetropia. That complete hypermetropia is being overcome. But how is it being overcome? Through excessive accommodative effort, very, very high accommodative effort. So by then what happens in the evenings, because of that straining, continuous eye straining, they have headache, they have watering, they have fatigue, they feel fatigue, their eyes feel tired, they have headache, they have watering. So these symptoms are known as asthenopic symptoms. And why do you have asthenopia here? Because of excessive accommodation. Hence it is also known as accommodative asthenopia. So but do the patients have vision problems? No. Patient has no vision problems. There's no visual defect. Why? Because the accommodation is overcoming that hypermetropia. But there is training of the eye because this overcome this how it is able to overcome that hypermetropia through excessive accommodation. So that is causing these asthenopic symptoms. But let's say the hypermetropia is even more severe. That is, the refractive error is even higher, where even after maximum accommodative effort, you are not able to correct it. Then what you'll have? You'll have both asthenopic symptoms and you'll have vision defect. What do you think the vision defect is? The vision defect, hypermetropia, is known as farsightedness. So they're able to see the far point. So how are they able to see the far point? Through accommodation. So some amount of accommodation they'll have, right? So some amount of accommodation, the parallel rays of light, they are being focused onto the retina. But near objects, from near objects, the light rays are not parallel. You have diverging rays coming to the eye. So even after accommodation, they are not being focused onto the retina. They are being focused behind the retina. So near objects, near point becomes blur. Now, what do you think happens in old age? Again, the same point. The far point is visible because of accommodation. But in old age, accommodation is weak. So both far point and near point become blur. But mainly when we think of hypermetropia, far point is visible because of accommodation and near point is blur because of diverging rays which cannot be focused onto the retina even with accommodation. So this is about symptoms. Asymptomatic, accommodative asthenopia, where you're able to correct it but through excessive eye straining, and then you have vision defects. Vision defects because of being focused behind the retina. That is, far point is visible but near point is blur. Next, coming to the signs of hypermetropia. Now, what are the signs of hypermetropia? Think about it. As I said, the most common type is axial hypermetropia, right? Where the eyeball is too small. So, the eyeball is small, the cornea is small, and when the eyeball is small, obviously the anterior chamber depth will be shallow. So, shallow anterior chamber. So, these are some of the small eyeball, small cornea, small anterior chamber, basically shallow anterior chamber. Similarly, small eyeball, so axial length of the eyeball is less. So when we do biometry, the axial length of the eyeball is said to be less. Then refractometry and retinoscopy. So this is to reveal the refractory error. And based on the refractory error, we can grade hypermetropia into low hypermetropia, moderate hypermetropia, and high hypermetropia. So less than 2 diopters, low hypermetropia. 2 to 5 diopters, moderate hypermetropia. And more than 5 diopters is high hypermetropia. This is about refractometry and retinoscopy. Then fundoscopy, where we see the fundus. Now, obviously, the eyeball is small. Now, when the eyeball is small, the fundus will also be smaller. And when the fundus is smaller, the optic disc, what you see first in the fundus, that will also be smaller. Now, this is pseudopapillitis. As you can see in this picture, now what is pseudopapillitis? See, here you can see, it appears as if the fundus is way more vascular. It has become very, very red. So why is that? The fundus appears more vascular with ill-defined red-gray margins. See, think about it. The number of blood vessels are the same in an emetropic eye, that is a normal eye, and in a hypermetropic eye. But a hypermetropic eye, the fundus is smaller. So the same amount of blood vessels, they get crowded into the fundus. So now it appears as if the fundus has more blood vessels than normal. But actually, it has the same vascularity. But because the fundus is smaller, it appears more vascular. So hence it is known as pseudopapillitis. Similarly, because the eyeball is very, very small, there is excessive image reflection within the eyeball. So this causes certain brilliance appearance, certain shining appearance. That is known as short silk retina. So upon fundoscopy, the 3 characteristic findings is small fundus, so small optic disc, pseudopapillitis, where it appears more vascular, as you can see in this picture, and short silk retina because of image reflection. So these are about the signs. Small eyeball, small cornea, shallow anterior chamber, short axial length of the eyeball through biometry, and fundoscopy, small optic disc, short silk retina, pseudopapillitis, and grading of the hypermetropia through refractometry, less than 2 diopters low hypermetropia, 2 to 5 diopters moderate hypermetropia, more than 5 diopters high hypermetropia. Next, coming to the complications. Now, complications, see, think about it. Basically, any patient with hypermetropia, what they're trying to do, they're trying to accommodate, right? Excessive accommodation to overcome it. So, when you're doing excessive accommodation, there is excessive ciliary muscle contraction. So, let's say the ciliary muscle contracts so much that there is overcorrection of the hypermetropia. Now, what will that manifest as? That will now manifest as myopia. But the patient actually has hypermetropia. So, this condition is known as pseudomyopia. This is a very rare condition. But apart from that, because of excessive accommodation, there is excessive accommodative effort that will lead to asthenopic symptoms. Now, asthenopic symptoms will make the patient rub their eyeballs more, and when they rub their eyeballs more, there is increased risk of infection. There is increased risk of infection when they rub their eyeballs more. There is increased risk of keratoconus because of continuous rubbing of the eyeball. The cornea can become cone shaped, etc. So that is one more thing. Then you have, as I told, when there's excessive accommodation, accommodation is always accompanied with convergence of eyeball. So that can lead to permanent convergence known as accommodative convergent squint. The squint is convergent and it's due to excessive accommodation. This is known as accommodative convergent squint. Then, as I said, the eyeball is smaller. So because the eyeball is smaller, the anterior chamber is shallower. And when the anterior chamber is shallower, the iridocorneal angle is narrow. And what does the iridocorneal angle have? It has the canal of Schlemm through which the aqueous humor flows out. So that is why they are at increased risk of acute angle glaucoma. Any sudden blockage of this narrow iridocorneal angle can lead to acute angle glaucoma. So very, very important complication, increased risk of acute angle glaucoma. And then amblyopia. Now, amblyopia, as I mentioned in previous videos, strabismic amblyopia. Why? Because of the squint. Anisohypermetropia can lead to refractory amblyopia. Bilaterally high degree of hypermetropia can lead to ametropic amblyopia. Now, for further explanation of what these types are, watch my amblyopia videos, you'll be able to understand. So, what are the complications? Shallow anterior chamber, so increased risk of acute angle glaucoma. Excessive accommodation, so hence leading to convergence of eyeball, leading to accommodative convergent squint. Then excessive ciliary muscle contraction leading to pseudomyopia. Then amblyopia can be strabismic, can be refractory, can be ametropic, and also asthenopic symptoms can lead to infections and etc. Last, coming to the management. Now, what do you think the management is? You have surgical management like LASIK. Okay, that is what, if you're a rich guy, if you can afford it, you can do it. But do we do it for everyone? No. The main line, the most common line of treatment is optical treatment, and obviously you will give convex lens plus prescription. For hypermetropia, we give convex lens. Why? See, think about it. Normally, the parallel rays of light are being focused behind the retina. But when we put a convex lens in front, it is converging it more so that it gets focused onto the retina. Simple. So, it acts as an extra converging layer. But before we give convex lens in the form of spectacles or contact lens, we have to obey certain rules. First step is, under cycloplegia, you will check the total hypermetropia. Now, if the manifest hypermetropia is less than 1 diopter and the patient is asymptomatic, then no need for any lens. You don't even have to correct it. Basically, patient has asymptomatic hypermetropia, very, very low hypermetropia, which is being corrected with very, very mild accommodative effort. But if the patient has symptoms, then the lens prescription is always total hypermetropia minus 1 diopter. Why are we subtracting 1 diopter? Because we don't want to correct the latent hypermetropia. The latent hypermetropia is corrected without any accommodation. The inherent tone of the ciliary muscle is correcting the latent hypermetropia. We just want to correct the manifest part, except in two conditions. In accommodative convergent squint and in amblyopia, we do full corrections where even the total hypermetropia is corrected. In amblyopia, along with that, we'll give occlusion therapy. To understand the occlusion therapy, you can watch my amblyopia video, as I said previously. So remember one thing, you have to first estimate the total hypermetropia under complete cycloplegic conditions. Then, if the manifest hypermetropia is very, very low and the patient is asymptomatic, no need for any convex lens. But if you want to prescribe a convex lens for a symptomatic patient, subtract the latent hypermetropia, and basically you have to correct only the manifest hypermetropia, except for conditions such as accommodative convergent squint or amblyopia, where we do complete correction of the hypermetropia, total hypermetropia correction along with occlusion therapy. So this is it for hypermetropia. I know this is a slightly longer video and I went a bit quick, but any doubts, please let me know in the comment section. And as always, thank you for watching.